Hello everyone, I'm Dr. Radhika PM, Associate Professor from Ramaya Medical College. Today we'll be discussing about the clinical anatomy of mammary gland. Disclaimer, all the images used in this presentation are from the textbook of anatomy, various internet sources. The images are used for teaching learning activities only. The video is done to help the undergraduates understand the clinical anatomy. I acknowledge the ownership of the images and give complete credit to them. Coming to the clinical case, a 48-year-old woman presents with the painless hard lump in her left breast for 3 months. On examination, the lump is irregular, firm, non-tender, poorly mobile with the restricted movement over the chest wall. A single mobile axillary lymph node was palpable and there was no discharge from the nipple. So this is the pure orange appearance, which is called as the which resembles the orange peel appearance. And here you can see this is the retraction of the nipple. So what is the diagnosis and anatomical basis of this condition? Why do you see this pure orange appearance, retraction of the nipple? We'll be studying, understanding about this in this presentation. Coming to the specific learning objective, at the end of the session, the student should be able to describe the clinical anatomy of mammary gland. Coming to the introduction, mammary gland is a modified sweat gland. It is present bilaterally in the pectoral region. It is present in both the sexes. In males and in immature females, it is rudimentary and it doesn't have the fibrous capsule. Coming to the location, it is present in the superficial fascia of the pectoral region. It extends from second rib to the sixth rib. It extends from the lateral border of the sternum to the mid-axillary line. It is hemispherical and it is in equal in size. A small part of the mammary gland extends superior laterally into the axilla and this is called as the axillary tail of Spence. This part of the mammary gland pierces the deep fascia and that foramen is called as the foramen of Langer. It is the opening in the deep fascia through which the mammary gland, which is present in the superficial fascia, pierces the deep fascia and it enters into the axilla. Now this is of clinical importance because this is a site for the highest percentage of the breast tumor. Coming to the mammary bed. So mammary gland is present on the pectoralis fascia. The base of the mammary gland is present on the pectoralis fascia and beneath that there are three muscles: pectoralis major, serratus anterior and external oblique. Pectoralis major is present in the medial two-third. The lateral one-third is the serratus anterior and inferior medially you will see the external oblique. Now there is a space between the base of the mammary gland and the pectoral fascia which is called as the retromammary space. Now here you can see this is the mammary gland and here you can see this is the pectoralis major muscle and this is the pectoralis fascia and this space is the retromammary space. This allows the mammary gland to move up and down and on the sideways. But in case of cancer, when there is a infiltration to this fascia, the mammary gland becomes fixed and you will see that it doesn't move with the tumor doesn't move up and down because it is fixed to this retromammary space and it penetrates into the pectoralis fascia and even into the pectoralis major muscle. Next, coming to the nipple. Nipple is a conical structure which is present at the fourth intercostal space. It consists of smooth muscles which is necessary for the erection of the nipple. And you can see the lactiferous ducts are present beneath the nipple. There are about 15 to 20 lactiferous ducts and it is richly innervated with the sensory receptors. Now coming to the areolar. Areolar is a pigmented circular area, and you will see a lot of tubercles which is called as the Montgomery's tubercle, and they are modified sebaceous gland, and what is present beneath this areolar is the dilated lactiferous duct which is called as the lactiferous sinus. It also contains a subareolar lymphatic plexus of the sapae. So these are the structures which are present underneath the areolar. Coming to the structure of the mammary gland, there are mainly three components in the mammary gland. The first one is the stroma. You can see here, this is the fibrous septa or the stroma, and it is called as the suspensory ligament of Cooper because it holds the skin with the underlying deep fascia. So you can see a lot of fibrous tissue. These are called as the suspensory ligament. And this is the glandular tissue which is made up of tubuloalveolar uh, glands which you can see, and there are about 15 to 20 lobes, and in between you can see these are the fatty tissue. Coming to the male breast is composed of the duct system without the alveoli, and they are supported by the fibrofatty tissue. They do not extend beyond the margins, but it is richly supplied by the lymphatics. So, breast carcinoma in males have a worse prognosis because of its rich lymphatics. So, this is one thing which we have to remember. It is not only females who are affected by the breast carcinoma, even in males they suffer from breast carcinoma, but the prognosis is worst in case of males compared to females. Now, abnormal and bilateral hypertrophy of male breast is called as the gynecomastia. It is usually seen in Klinefelter syndrome, in some endocrine disorders, liver cirrhosis, and because of some drug intake. So this is the gynecomastia, and this is after surgery. Coming to the arterial supply, the upper part is supplied by the superior thoracic and the acromiothoracic artery, and the lateral part is supplied by the lateral thoracic artery. Now these are branches of the axillary artery, and medially it is supplied by the perforating branches of the internal mammary artery. So this is the internal thoracic artery, or also called as the internal mammary artery, and here you can see the base is supplied by the posterior intercostal arteries. Coming to the venous drainage, the veins which drains the mammary gland are mainly the axillary vein, internal thoracic. This is the axillary vein. So you have the internal thoracic and the posterior intercostal veins. They form a circle around the areola, which is called as the circulus venosus, and from there in a radial manner the veins there is a venous drainage. Now, one important thing we have to know in the venous drainage is from the posterior intercostal veins, the metastasis can spread to the vertebral venous plexus, and from there it can go into the intracranial sinus, and from there it can go into the vertebra and skull bones. So metastasis, that is the spread of carcinoma from mammary gland to the vertebra and skull, are mainly through this posterior intercostal veins, from where it connects with the vertebral venous plexus, and from there it spreads to the intracranial sinuses and then to the vertebra and the skull bones. Now coming to the lymphatic drainage. Lymphatic drainage is important because spread of carcinoma is mostly through the lymphatics. Now there are two groups of lymphatics. One is the superficial lymphatics, the other one is the deep lymphatics. Superficial lymphatics, those draining from the overlying skin excluding the areolar and the nipple, whereas deep lymphatics, those draining the parenchyma of the breast, including the areolar and the nipple. Now, if the mammary gland is divided into 4 quadrants, from the lateral part, it mainly drains into the axillary group of lymph nodes. So, in axillary group of lymph nodes, we can see the anterior group. Here you can see this is the posterior. Here you can see the lateral group. Then you can see the central group. Then you can see the apical, and from here it drains into the supraclavicular. So there are 5 groups in the axillary group of lymph nodes. So this is the anterior. Here you can see the posterior. Then you can see the lateral. This is the lateral. This is the central group, and this is the apical group. Now from the medial quadrant, it mainly drains into the internal mammary nodes. And from the lower part, it drains into the posterior intercostal nodes. And from the inferior medial, it drains into the subdiaphragmatic and subperitoneal, through which it can metastase to the abdominal organs. So this is, you can see the internal mammary. From here it can spread to the opposite mammary gland. Coming to the route of metastasis, from the medial lymphatics to the parasternal, and then it can also metastase to mediastinal lymph nodes. So this is how the mammary carcinoma of breast can spread to the mediastinum. Across the sternum, the lymphatics can go to the opposite side to the contralateral breast. From the subdiaphragmatic lymphatics to the nodes of the abdomen, and then to the liver, ovaries and peritoneum. So these are the routes of the metastasis. Coming to the nerve supply, the mammary gland is supplied mainly by the anterior and the lateral cutaneous branches of 4th and 6th intercostal nerves. They convey the sensory fibers to the skin, autonomic fibers to the smooth muscles and the blood vessels. One thing we have to remember here is secretion of milk is not under the neural control, but it is under controlled by the prolactin, which is secreted by the pituitary gland. Now coming to the applied anatomy, in breast carcinoma, the infiltration of the cancer cells along the ligament of Cooper results in the retraction of the overlying skin. So you can see the skin dimpling. This is mainly because of the retraction of the overlying skin because of the infiltration of the cancer cells along the ligament of Cooper. And this leads to the fixation of the tumor to the underlying fascia. Now, the extension of the growth along the lactiferous ducts can result in the retraction of the nipple. So, this is the retraction of the nipple, which is mainly due to the extension of the growth along the lactiferous ducts. Now, obstruction of the cutaneous lymphatics results in the air follicles over the lump to be retracted, resulting in the purdo orange. So purdo orange is mainly because of the obstruction of the cutaneous lymphatics, and because of this the air follicles over the lump gets retracted, and because of spread of metastasis you will have the enlargement of the axillary lymph node enlargement. Now sometimes the metastasis can spread to the ovaries, and the secondary deposits on the ovaries are called as the Krukenberg tumor. So these are the applied anatomy which you have to know regarding the cancer of mammary gland. So this is the pure orange, and here you can see the retraction of the nipple. So skin dimpling is because of the involvement of Cooper's ligament. Nipple retraction is because of the fibrosis of the lactiferous duct, and axillary lymph nodes are enlarged because they are the primary lymphatic drainage pathway. Now the differential diagnosis for the breast lump or the nodulus. If the breast lump is hard and fixed, it is most probably a malignancy if it is postmenopausal, I mean in an elderly female. Whereas if it is mobile, soft, it is most probably the benign fibroadenoma seen in young females. And fibroadenosis is a benign condition. So always don't think if there's a lump, it is a malignancy. So we have to do the test, we have to do the mammogram, we have to do the FNAC and diagnose it, and only then we can tell whether it's a malignancy or a benign condition. Here's one more case. A 22-year-old woman presents to the outpatient department with the complaints of lump in her right breast for the past 6 months. The lump is painless, gradually noticed during the bathing. No increase in the size, but occasionally feels more prominent before the menses. No history of nipple discharge, trauma or infection. And there is no associated history of fever or weight loss. Weight loss, you have to ask for the weight loss, because in most of the malignancy, weight loss will be one symptom which you will be seeing. So the lump is present in the upper outer quadrant, firm, rubbery consistency, smooth surface, well circumscribed, mobile. Okay. So this is one thing you have to know. When the lump is fixed to the underlying, okay, most probably it will be a cancer. If you are not able to hold it, if it is moving, then you have to think about the fibroadenoma. If it is not attached to the skin, muscle or chest wall, there is no axillary lymphadenopathy, the most probable diagnosis will be the fibroadenoma. So we do a procedure which is called as the mammogram, in which a low energy X-ray is used to examine the human breast, and it is used as a diagnostic and also screening tool. The goal of mammogram is for the early detection of the breast cancer through detection of characteristic masses and microcalcification. So yearly screening of mammogram starts at the age of 40 years. So this is the mammogram, the procedure and the image, and here you can see the calcification. Coming to the FNAC or fine needle aspiration cytology, here a fine needle is passed through the lymph node and the fluid or the lymph tissue is collected, and it is processed and we see under the microscope for any cancer or a benign condition. Sentinel lymph node biopsy, it is to identify and remove the first lymph node where cancer cells are most likely to spread from a primary tumor. It's used for the stage cancering and to determine if it is metastasized. So here you can see what they do is, during the procedure, a tracer, usually a dye or a radioactive substance, is injected near the tumor to help the surgeon locate the sentinel nodes, which are then surgically removed and tested for the cancer cells. Coming to the surgical anatomy, so they usually, if they detect a mammary carcinoma, they do a radical mastectomy or modified radical mastectomy. In radical mastectomy, they remove the breast, axillary lymph nodes, and also the pectoralis major. Whereas in modified radical mastectomy, they preserve the pectoralis major muscle. Now, when they do other mastectomy, there are two nerves which are likely to damage. One is the long thoracic nerve and the second one is the thoracodorsal nerve. Now, if there's an injury to the long thoracic nerve during the surgery, this will result in the winging of scapula. And if the thoracodorsal nerve is injured, this results in the injury to the latissimus dorsi. Coming to the developmental anomalies, amastia means absence of breast. Athelia is absence of nipple. Polymastia is If there is a supernumerary breast, it is called as the polymastia. If there are supernumerary nipples, they are called as polythelia. So, to summarize, today we have learnt about the location of the mammary gland, structure, arterial supply, lymphatic drainage, nerve supply, and clinical anatomy of mammary gland. Thank you.